Hi everyone, my name is Hugo Monrroy. I am gastroenterologist and endoscopist, adjunct instructor of the gastroenterology department of Pontificia Universidad Católica de Chile. With the co-authors, we are very grateful to the editorial board of Gastrointestinal Endoscopy Journal for the opportunity to discuss the results of our study titled Use of N-acetylcysteine plus Simethicone to improve the mucosal visibility during upper gastrointestinal endoscopy, a double-blind, randomized control trial. One of the key elements during upper gastrointestinal endoscopy is the complete visualization of gastric mucosa. Mucus, foam, and bubbles interfere with adequate endoscopic visualization. For this purpose, many antifoaming and mucolytic agents are widely used in Asian endoscopic centers, unlike Western countries. The impact of antifoaming agents compared to fasting alone, the most common condition in Western countries, has not been evaluated yet. The aim of this study was to evaluate the use of antifoaming agent disposable on our clinical practice in the preparation for upper endoscopy. This was a trial with two control groups, that was no intervention and water 100 milliliters, and three intervention groups, Simethicone 200 milligrams, Simethicone plus N-acetylcysteine 500 milligrams, and Simethicone plus N-acetylcysteine 1000 milligrams. During endoscopy, gastric visibility was evaluated in 4 segments. The sum of the visibility scores was defined as a total visibility scale, TVS, ranging from 4 to 16 points. Endoscopic visualization was considered to have adequate visibility when TVS was less than 7 points and insufficient visibility when TVS was 7 points or higher as primary outcome. As the main outcome, adequate visibility was more frequent in N-acetylcysteine groups compared to no intervention and water. As a secondary outcome, the median amount of water used was higher in the water group. Comparison between groups showed a significantly lower use of water in the Simethicone plus N-acetylcysteine 1000 group. The group that required less time to complete visualization of the entire gastric mucosa was the group that used Simethicone plus N-acetylcysteine 1000 group. The intervention groups taken together had a higher rate of lesion detection in endoscopy compared to the control water alone group. No adverse reaction from study drugs were observed. To the best of our knowledge, this is the first study to use a control group of no intervention, and this option should certainly be included in any comparative study dealing with preparation for endoscopy, as most patients worldwide undergo an endoscopy without any preparation in Western countries. Considering that the demand for endoscopic procedures is increasing and that efficiency should be optimized, it's imperative to incorporate strategies which can improve the quality of the procedures while saving time. Although improved mucosal visibility doesn't necessarily improve clinical outcomes, endoscopic premedication may be helpful to increasing the detection rate of early cases. Large randomized clinical trials are needed to confirm the utility of upper endoscopic premedication for detecting more gastric lesions and identify early gastric cases. These findings suggest that the use of N-acetylcysteine in both concentrations that were studied plus Simethicone did provide better results in the visualization of the gastric mucosa. Interesting findings in this study is that the use of water as preparation for endoscopy had a higher score in TVS, required more water for adequate mucosal assessment, and had less lesion detection during endoscopy than all other groups, including the group of no intervention. Most studies have administered water as a placebo control ranging from 60 to 100 milliliters. These results suggest that the use of water alone as preparation for upper endoscopy could be detrimental. Some point for discussion would be the usefulness of N-acetylcysteine plus Simethicone compared to Bernays. that is the mucolytic agent used in Japan, but not available in Western countries. At least a study from Taiwan compared both agents and showed equal effectiveness. N-acetylcysteine is widely available in Western countries, therefore it appears to be an adequate strategy for gastric preparation. On the other hand, the price should not be a factor limiting its widespread application. In our opinion, another important point for discussion is the interval between administration of gastric premedication and the moment of endoscopy. For PRONAS, it was shown in previous studies that 10 to 30 minutes prior to endoscopy is an adequate time interval. In our study, the agent was given 20 minutes prior endoscopy. However, after finishing the study, we have experienced cases when the gastric visibility was poor and the preparation had been taken much longer than 30 minutes, or also sometimes just immediately prior of the endoscopy. The most adequate time interval for N-acetylcysteine before the moment of endoscopy should be determined in future studies. In conclusion, these findings show that the use of N-acetylcysteine plus Simethicone before the upper gastrointestinal endoscopy improves the visibility of the gastric mucosa and reduces the volume of water needed for adequate visibility, which may increase the diagnostic yield of the upper endoscopic examination.